Welcome. My name is Garry Kauffman. I want to thank you for watching this webcast on Critical Access Hospital. We're going to talk about reimbursement. With us for this webcast is Mr. David Passetti, who's the Senior Executive for a Critical Access Hospital. Before we dive into the questions, maybe we should just take a step back and define what a critical access hospital is. The critical access hospital programs were started in the late 1990s. And last time I looked, there were over 1,300 critical access hospitals in 45 states. So they're everywhere, but a lot of respiratory therapists may not know about them because they work in the traditional, larger acute care hospital. So Dave, let's start the conversation. Can you tell us what is a critical access hospital?
Critical access hospital. Critical access is a federal designation, generally for smaller hospitals that are geographically removed from other hospitals or bigger hospitals. There's certain levels of confinement that come with that, in that you can only have up to 25 beds. The average length of stay, while that's currently under waiver due to COVID, normally would be 96 hours. You have to have a relationship with a tertiary care center, and generally they're kind of known as rural hospitals. They have to be geographically positioned so far away from other hospitals. So in our case, we're positioned between uh, two kind of metropolitan areas that are a fair distance away.
It sounds like critical access hospitals play a very valuable role, and that they're kind of a niche role that provides much better access to folks, particularly in the more rural areas. Let's talk about hospital reimbursement. How are critical access hospitals reimbursed? And if you just talk a little bit about, is it different by the different payers, whether it be Medicare or Medicaid or commercial insurance?
Yeah, it's totally different. The payment platform, um, through Medicare, is all cost based. It's all based on an annual cost report that is usually done by the CFO of the company, um, and the Medicare payment for inpatient care is based on a per diem rate that's established through the cost report. Medicaid, a little bit different method in our state. It's supposed to be cost based, but the actual payment is not cost based, and that's sort of reimbursed by an annual wraparound payment that comes um, once a year. That's supposed to make up that difference or that gap between what you got paid and what the cost to provide that care was.
And then, does commercial insurance or private insurance, do they play a role in your reimbursement?
Certainly, we take care of patients that have commercial insurances, and they're largely based on contract, just like they would be in other facilities. And they're all a little bit different. You know, Unfortunately, it seems sometimes, because there's very little leverage from a small hospital with an insurance company, the contracts are not always so favorable uh, for critical access hospitals when it comes to the commercial insurances. So, I sometimes feel like we get a little bit penalized, not having that quote unquote big corporate status with the insurances.
Dave, you mentioned that Medicare is a cost plus model. Medicaid is a different model. And then you said there's all kind of different contracts with commercials or private. Is there any one particular type of methodology for reimbursement? Is that capitated, cost plus, charge minus for the commercials?
They're all a little different. To my knowledge, there are no commercials that we have away from Medicare Advantage plans, which are commercialized. But the other commercial products, as far as I know, we have none that are cost-based reimbursement. They're all individual contracts. Um, they quite often, unfortunately, there are some that never cover the costs. Um, so the answer to that is largely no. There are no cost-based commercials.
You mentioned this is how reimbursement is today. It's different from Medicare, Medicaid, and maybe many different ways for private insurance. Are you anticipating, or have there been any announcements for changes for critical access hospital reimbursement?
In our state, there's been a shift to attempt to go to a global payment system, um, and we were one of the pilot hospitals in our state, whereby the payment platform, especially it started out with Medicare and Medicaid, were flattened out, if you will. They took a look, basically like a 3-year rewind, looking at your volumes and your payments and so on. And basically, what they've done is they've flattened out our payments, so we receive a monthly payment from Medicare, 1/12 each month for the amount that we should be receiving throughout the year. It stops the peaks and valleys of the reimbursement, that are sometimes a hardship to critical access hospitals.
Okay. Now, we talked about reimbursement at the global hospital level. How is that at the department level, whether that be lab or imaging, or in our case, respiratory therapy? Do the RTs or the RT department bill or charge? And does that play a role into your actual final reimbursement?
Yeah, like with Medicare, everything is cost based. So those, it doesn't matter what the service might be, it all rolls into the overall cost to take care of an inpatient for by the day, and we do get a per diem rate based on that, and all those costs, all those applicable costs, whether they be respiratory therapy or physical therapy or occupational therapy or nursing service, so on, that all rolls into that cost. Um, the respiratory therapy in a lot of critical access hospitals is done a little bit differently than it is in big hospitals, and that some cause or critical access hospitals don't even have a respiratory department per se. It's mostly run by nurses in some of the smaller ones, and we're one of those.
Dave, you mentioned that Medicare, Medicaid, and commercials pay in different or many different ways for labor, supplies, pharmaceuticals, etc. But what about capital equipment? Are you able to get reimbursement for on a depreciation scale for the use of ventilators or bilevel or high flow systems?
It is run through depreciation scale. Um, Basically, and it's more difficult for cause in general to add, do large capital projects through, of equipment or improvements to a facility for that matter, just because, it's you're paying for it up front, and it takes a long time to recover that through a cost based depreciated scale.
Okay. Now I want to circle back to something else you said. It just struck me. Let's say a breathing treatment. You can reimburse for the labor and for the pharmaceuticals. What about the disposable costs? Is that all go into that total cost basis, whether it be a vent circuit or humidified high flow, or even a nasal cannula for that
Yeah, it does. That all goes into the costs. It's not nothing is reimbursed, by the item on this cost-based reimbursement model. It basically it's all the costs, in speaking overly simple, you take all those costs and divide it by patient days, and you get the cost to take care of a patient per day, and that's where the per diem rate essentially comes from for the Medicare.
matter? And the reason that strikes me as important is that far too frequently we hear from respiratory therapists, I'm not permitted to utilize the best device, supply item, protocol, whatever, because it's more costly. And with a few exceptions, like hospital acquired conditions, where you might select a soft cannula over a hard cannula to avoid the hack, there's a lot of pushback from that. So that kind of leads me in the next question. Do critical access hospitals receive higher reimbursement for one therapy over another? And does this vary by the different payers?
Yeah, I was going to say, again, referring to Medicare, everything would roll into cost. All those services and supplies and pharmaceuticals and so on would roll into the cost. When you get into the commercial payers, for us, again, it's very, very contract dependent, and some of them are certainly a little bit more friendly than others, um, you know, based on codes and so on. what is going to be reimbursed and what is not. And I certainly can sympathize with what you're saying, that there are certain things that are not reimbursable, and makes it makes it tough to use a supply that is very, very expensive when you know there's going to be no reimbursement for it. And many times, we don't even know, like the end user, the nurse or the doctor making the order, they certainly many times have no idea knowing if a supply or a service is reimbursable when they order it. So basically, we usually just do what's best for the patient, based on the physician order, and sometimes we suffer on the back end with reimbursements.